As previously we have discussed the first type of conjunctival and corneal cicatrizing disorders, okay? So now we will discuss other types of conjunctival and corneal cicatrizing disorders. The second one is ocular cicatricial pemphigoid. It is an autoimmune condition which is recurrent and which is characterized by the formation of bullae on the surface of mucous membranes. And ultimately these bullae will rupture and will cause scarring, okay? So in the mucous membrane like conjunctiva, there will be the formation of recurrent bullae, and these bullae will ultimately rupture and will cause scarring, okay? Etiology and pathogenesis. As it is an autoimmune condition, so it involves type 2 hypersensitivity reaction. We know the basic knowledge of type 2 hypersensitivity reaction, so I will not go into that details. I will give only a short overview. Type 2 hypersensitivity reaction is that when there is some problem with the immune system, what will happen? That the immune system will produce antibodies which will attack its own cells, okay? So the immune cell will produce antibodies, and these antibodies will be directed against its own cell surface antigens and will attack the cells, and these cells will be destroyed. So that's why it is also called cytotoxic type of reaction, okay? The antibodies mostly involved are IgG and IgA. In the age group which are presented with this condition, they are mostly women over 60 years old, okay? The clinical features. The clinical features are that there will be a long history of conjunctivitis. A long history of conjunctivitis which will not improve with topical therapy. So, a long history of conjunctivitis which will not respond to any topical therapy is the indication for ocular cicatricial pemphigoid if the age group is over 60 years old female, okay? So what is happening? What is happening if the condition is happening again and again and it is not responding to any topical therapy? We know that it is an autoimmune condition and which there is the formation of bullae again and again. When these bullae form, so they will rupture and will cause scarring. So what is happening? Because of these rupturing of bullae, it will cause different types of complications if the condition is not managed timely and properly. These complications, for example, we know that we have different types of glands in the conjunctiva. So this scarring will destroy the glands like the mucin secreting glands in the accessory lacrimal glands. So when these glands are destroyed, what will happen to the tear film? Tear film will be gone. When there is no tear film, the condition is called dry eye syndrome. So the complications include dry eye syndrome. And another thing, we know that this is the cicatrizing disorder. So what will happen? It will, the upper and lower eyelids, they will stick together, and this condition is called ankyloblepharon. So the complication can be ankyloblepharon, okay? Another complication can happen is that the tarsal conjunctiva and the bulbar conjunctiva can stick together. So it is called symblepharon, okay? The upper eyelid and the lower eyelid sticking is called ankyloblepharon, and the sticking of the palpebral and bulbar conjunctiva is called symblepharon. So these complications can happen. Another complication which is that is when there is scarring inside the palpebral conjunctiva, what will happen? It will cause the lower lid margin or upper lid margin to move inward toward the eye. This is called entropion. So entropion can happen, okay? Entropion can happen, and it will also cause the lashes to touch the eye globe. The condition is called trichiasis, okay? So what is happening? If the bullous reaction is not controlled, it will cause so significant scarring that the complication can be dry eye syndrome, ankyloblepharon, symblepharon, entropion, trichiasis, okay? So it should be managed properly and timely. How can we diagnose the condition? The condition can be diagnosed, for example, if we take biopsy. So in ocular cicatricial pemphigoid, Biopsy is 83% positive for the condition, okay? But we can also diagnose the condition from its clinical features. Now, treatment. We can do topical treatment and systemic treatment. In a topical treatment, as we know that there can be the dry eye, so first we will prescribe artificial tears in the form of ointments and drops. Okay, as we know that the condition is recurrent, so to control, when we control the inflammation, the complication will also be stopped. So we can give steroids and cyclosporine in order to control the inflammation and hence complications. We can also help the damaged epithelium to grow and to maintain its structures. So we can also give retinoic acid in order to prevent the damaging effect of the inflammation over the conjunctiva. At last, as we know that we have used steroids and cyclosporine, immunosuppressants have been used, so there is a chance of bacterial infection. So we will prescribe antibiotics. The systemic therapy is that, remember, Dapsone is the drug of choice in ocular cicatricial pemphigoid. If we do not have Dapsone, then we can use alternative drugs like immunosuppressant drugs like azathioprine, methotrexate, cyclosporine, etc. can be used in place of Dapsone. We can also give steroids and systemic immunoglobulin. Okay, so this is ocular cicatricial pemphigoid. Now the third condition is Stevens-Johnson syndrome. Stevens-Johnson syndrome is the allergic inflammation of the mucous membrane and skin due to drugs and microbes, and which is characterized by the formation of Vesico-Bullous reaction. So there will be the Vesico-Bullous reaction due to the drugs and microbes on the skin and mucous membrane. Like in ocular cicatricial pemphigoid, there will also be a bullous reaction, but in this case it is due to the reaction to the drugs and microbes, and it is most commonly it is involving the skin and mucous membrane equally. As we know that in ocular cicatricial pemphigoid, the mucous membrane are mostly involved, but in Stevens-Johnson syndrome, the mucous membranes and the skin both are involved equally. Okay. Now, etiology and pathogenesis. Etiology is that it is a type 4 hypersensitivity reaction in contrast to ocular cicatricial pemphigoid. And type 4 hypersensitivity reaction, what is happening when there is the particle of the drug and when there is the microbes? The drugs and microbes are, for example, the drugs which are mostly causing this type of reaction. These are drugs such as sulfonamides. Okay, sulfonamides. We have drugs like paracetamol. Okay, analgesic paracetamol. Okay, and we have the drugs like anticonvulsant drugs. Okay, so these drugs can induce anticonvulsant. These drugs can induce Stevens-Johnson syndrome. Microbes such as herpes simplex virus, adenovirus, mycoplasma, pneumonia, bacteria. Okay, so these all substances, the drugs and the microbes, can induce Stevens-Johnson syndrome. So what is happening in this case is the pathogenesis is type 4 hypersensitivity reaction. When these drugs and microbes, when they comes into the body, the T cell will encounter this particle and it will carry these particles to the lymph nodes, and hence in the lymph nodes the immune system will be activated by forming and different types of immune cells. Okay, that's why it takes some time in order to carry the microbial or drug particles to the lymph nodes and activate the immune system. That's why it is also called delayed type of hypersensitivity reaction. Okay. In contrast to the ocular cicatricial pemphigoid, the age group, mostly they are children and young adults, and mostly they are also women. Okay. So when a patient present with these clinical features, okay, with alarm conjunctivitis and not responding to topical therapy. And the patient is old age woman. It is most probably ocular cicatricial pemphigoid. And if the patient present with these ocular features as we will discuss, and the younger and children, girls, so this will be Stevens-Johnson syndrome. For example, with these clinical features, the patient will have red watery eyes. There will be, we know that this is the allergic reaction, so there will be follicular conjunctivitis, there will be follicles on the conjunctiva, okay? There will be crusting lesion on the lid margin. So on the lid margins, if this is the lid margin, so in these lid margin, there will be crusting lesions, okay? And the cornea can also be involved, like in the cornea will have punctate epithelial keratitis, micro erosion, etc. Okay. Now we will also have some systemic features in Stevens-Johnson syndrome. As the condition is also involving skin, so we will have systemic features. The systemic features of the Stevens-Johnson syndrome are, there will be the bulla in the mouth. So there on the tongue and in the mouth there will be the bullous lesions, okay? The crusting lesion will also be present on the lips, like the crusting lesion, the hemorrhagic crusting lesion on the lid margin, there will also be crusting lesion on the lips. So bullous lesion in the mouth, crusting lesion on the lips, we will have target lesion on the skin. So the target lesion will be present on the skin, okay? Target lesion. Other mucous membranes will also be involved, like the esophagus, the trachea, the anal and genitalial regions can also be involved. There can also, the bullous region can also be seen in other mucous membrane areas, okay? So, when a patient presents with these features, with the red watery eyes, hemorrhagic crusting, keratopathies, target lesions, bullous lesion on the tongue, in the mouth, crusting lesion on the lips, and lesion on other mucous membrane areas such as esophagus, trachea, and anal region, genitalia, okay? So, and it is a younger girl, younger or a child girl, so it is most probably Stevens-Johnson syndrome, okay? Now, we have some types of Stevens-Johnson syndrome. Stevens-Johnson syndrome, it can be erythema multiforme minor, erythema multiforme major, and toxic epidermal necrolysis. So in erythema multiforme minor, we will only the skin will be involved, okay? And erythema multiforme minor, only the skin will be involved, okay? And erythema multiforme major, skin and mucous membrane both will be involved. And when the Stevens-Johnson syndrome becomes severe, it is called toxic epidermal necrolysis, okay? So the minor form is erythema multiforme minor, erythema multiforme major, and toxic epidermal necrolysis is the severe form of Stevens-Johnson syndrome. The treatment, most of the treatment of Stevens-Johnson syndrome is similar to ocular cicatricial pemphigoid, okay? Now, the fourth condition is Parinaud Oculoglandular syndrome, okay? Oculoglandular syndrome. What is happening in this scarring disorder in Parinaud Oculoglandular syndrome? It is a unilateral granulomatous conjunctivitis which is associated with ipsilateral lymph nodes lymphadenopathy. So it is a unilateral granulomatous conjunctivitis which is associated with ipsilateral lymphadenopathy. This is called Parinaud Oculoglandular syndrome. It is mostly caused by Parinaud Oculoglandular syndrome. It is mostly caused by tularemia and cat scratch disease. Okay, so cat scratch disease is caused by a bacteria which is called Bartonella henselae. So Bartonella henselae and which is causing cat scratch disease and tularemia. These are the most common causes of Parinaud Oculoglandular syndrome. and which there is, guys, which is there is the granulomatous inflammation in the conjunctiva, okay, and this granulomatous inflammation of the conjunctiva and granulomatous conjunctivitis mostly caused by the cat scratch disease and thalassemia. Other bacteria can also cause the condition like the tuberculosis, like the syphilis, like the rabbit fever. So these all can cause the Parinaud Oculoglandular syndrome, but the most common causes they are cat scratch disease and thalassemia. Okay. Now how the patient will present? The patient will present with red, tender eyes, and there will be the pre-auricular lymph nodes, they will be tender. So as in the definition I told you, that unilateral inflammation of the conjunctiva associated with lymph adenopathy, pre-auricular lymph adenopathy. Okay, so the patient will present with red, tender eye. There will be tenderness in the eye, and when we touch the pre-auricular lymph nodes, they will also be tender. With these all features, there will be systemic feature like fever. Okay, so this is the presentation of a patient. Now, how can we diagnose the condition? The condition can be diagnosed by lab investigation such as CBC, but we can take biopsy, we can also take secretions from the conjunctiva, and we can send them for laboratory investigation such as culture. Okay, so CBC can be done, biopsy can be done, culture can be done, and we can diagnose the condition. A patient present with red tender eyes and with tender pre-auricular lymph nodes, okay, and with systemic features like fever. The treatment options, they are mostly, as the condition is mostly bacterial, so the treatment options are antibiotics.